All right, as everybody's filtering in, welcome to our weekly grand rounds. We have a special visitor from Stanford today. Before we get started, just a reminder, our residency interviews are coming up next month. So everybody should have that on their calendars. Residents are expected to be there, excused from clinical work. And then we appreciate all of your involvement. Faculty, there's the social on Thursday evening. And then appreciate all the faculty who are participating in interviews, but just make sure your calendars are marked January 16th, 17th. And then this will be our last grand rounds before the holidays, so happy holidays. And then we'll resume in early January. But for introduction for today's speaker, I'll turn it over to Dr. Lotz.
Okay, so it's my pleasure today to introduce Mike Longacre as our speaker for grand rounds. Mike is professor of plastic and reconstructive surgery at Stanford, and he earned his bachelor's degree from Michigan State. And a fun fact this group would appreciate is he was a freshman teammate, Magic Johnson, when they won the national championship and beat Larry Bird and Indiana State. So how cool is that, right? So yeah, exactly. Yeah, most people that would be enough, but he kind of kept going. So he got his medical degree at Harvard, completed a surgical residency here at UCSF, plastic surgery at NYU, craniofacial fellowship at UCLA. He also has an MBA from a combined program with UC Berkeley and Columbia. The majority of his research training initially was here at UCSF with Mike Harrison, and he was part of the team that discovered that at a certain stage of development, you could heal without scar, and the mechanisms by which that occurs and potential translation to patients is something he spent 30 years working out, particularly how mechanical forces influence cell fate and differentiation. And I think there's a really interesting story between the basic discovery research and clinical applications that Mike will get you excited about. His research has opened up fields of fibroblast heterogeneity, regeneration during wound healing, stem cells. His lab identified the mouse skeletal stem cell in 2015 and the human skeletal stem cell in 2018. And he's super prolific. And he's the only person I know that when you Google Mike Longacre at Stanford, there's a big full page warning that comes up. It says, if you're feeling professionally inadequate, don't go any further, go back. He's got over 1,000 publications, 100 patents. His H-index is over 154, super prolific. And I've had the pleasure of working with Mike closely over the last 8 years or so as part of the NIH-supported Tissue Regeneration Resource Center, CDoctor. And we've been collaboratively identifying technologies that are at early stages and then moving those to FDA approval of human clinical trials. So it's a really fun program, and I think something that NIH is really proud of, and we'll be extending that next year through a program called APEX to expand the tissue indications and also include in other technologies like sensors. So I'm happy that Mike's here today to tell you about all his great work and forward to the conversation we'll have to this morning. Thanks, Mike.
Thank you, Jeff, and it's a pleasure to be here today. I have no formal disclosures, but I want to disclose that the true story is I matched at UCSF in general surgery, wasn't certain what I was going to do. June 20th, 1984. Trying to think. Bill Murray was the chair of orthopedic surgery, as I recall. So I wanted to go straight through and be a heart surgeon and then do congenital heart surgery because the chair of surgery was Paul Ebert. So we have a new chair of surgery, comes in exactly halfway through. So about right now in whatever that would be, 89 or 90, I meet with Haile DeBass, who you may know became dean and chancellor. So he looked at my folder, half glasses like me, gray hair like me, but a lot smarter than me. Great accent, by the way. And said, wow, you're a really great student. You've never done any lab work. So frontal release is a funny thing. You usually have it under age 2 and after age 90. But I said, nice to meet you, Dr. Bass. I don't want to do any research. So he said, frontal release. How old are you? I said, 28. He said, that's unusual. He said, so can you read me your name tag? I thought, oh, I read mine. He said, could you read mine? I said, yes. He said, okay, this is an important question. How do you pronounce your last name? I said, Longacre. He said, okay, Dr. Longacre, I'm going to ask again. How would you like to do a year of research? And I thought, this sounds important. And I think he established the food chain. So I said, I'd love to. So he writes down trainable question mark and shows it to me. He said, so that's where we're at from here. I'm like, awesome. I'm like, awesome. So in June, 6 months later, I get a typed, there's no, by the way, there's no internet in those days for the residents. So I get my letter saying, you've been assigned the following laboratory for July 1st. And it was Michael Harrison, pediatric surgery. So I go in Dr. Harrison's lab. I didn't do anything for 3 or 4 months. Was moonlighting and really enjoying it. Dr. Harrison looks at me in October of '87, roughly, and says, "How's the moonlighting going?" I said, "Fantastic." I'm not doing much of it, right? I'm thinking, why can't I filter what I'm thinking? He said, "Okay, you don't seem to have a project." I said, "Well, I'm working on some things." He said, "Moonlighting." I said, "No, I mean some other things." So it was heterotopic heart transplantation of mini swine, which is not what I'm known for. So that was going nowhere. So he said, "Why don't you look at the way we heal before we're born?" What did I do? I blurred out, "That doesn't seem to be a big medical problem. You've done like 9 cases, right?" And everyone looks at me like, I'm like, "Yeah, right, again." So he said, "Look, I put Gore-Tex patches on a diaphragmatic hernia in utero. The child is born 16, 20 weeks later when preterm labor, wins at some point. And I don't really see a redness around the Gore-Tex patch." So this is the first important lesson, is the experienced clinician. My whole career is based on that observation. He said, "But you can get redness around a Band-Aid or sutures in a day. So why don't you look at that?" So long story short, my forced 1 year in the lab became 4 years. Same chair said, "Okay, you've seen patients for 3 years. Now you've been in 4th grade for 4 years, not seeing anyone. Either finish or come on the faculty, get your graduate degree." So I decided to finish my residency, but that's the real story. UCSF made my career 100%. I'd never been in a lab in my life. And the experienced clinician of someone who had a 200% mortality in September 18th, 1981, when they did the first fetal case. Also, the other story there is enabled by technology, ultrasound. You could identify 5 fingers, 5 toes, whatever. So anyway, that's my disclosure. UCSF made my career. So fibrosis, I thought I'd talk about. My lab has a long history in skeletal stem cell work. And I'm not quite ready to talk about that. I had a postdoc who became an assistant professor and internationally known, who died in March. Very sad story. So I've been winding down his lab, which is hard to do for 12 or 14 people, but they all have spots. But I'm not quite ready to talk about skeletal stem cell biology, because that is a field that he made discoveries in. But I'm going to talk about fibrosis. And I think everyone who makes an incision here or treats a patient here, or even if you don't, suffers from the response to injury that falls short of regeneration. Tom Wynn at Pfizer, who had the great pleasure of co-chairing a fibrosis meeting internationally for Keystone last week. And it's really amazing that almost half the people in America die of something that you and I would call fibrosis, but you never hear that term. So I'm here to say fibrosis is a big deal, and I'm going to talk about what we do. During the pandemic, I co-chaired a Howard Hughes meeting with 2 other colleagues, and we wrote this perspective trying to identify roadblocks for why we don't regenerate and why we do in utero and other animals do, and then identify some therapies. So I'm going to go over those, an example of mechanotransduction inhibiting it, to give you no scar. This is a broad topic. We just published a review article on it. For those who are having trouble sleeping, I recommend this. That you read before you go to bed. But it turns out that there are lots of different ways that fibroblasts, for example, as the effector cell that lays down matrix, can sense calcium channels. We're going to talk about YAP-TAZ. We have published extensively on FAK and other ways, but I'm trying to inhibit how a fibroblast responds to mechanical force. So these are the organs we work in. What most people know is this, but I'm here to say that we have all these organs, and once again, it's been a privilege. Oh, there's one other disclosure I have. I was recruited back to the Bay Area 24 years ago to work a week at a time at the North Campus. Some may be old enough to remember what that meant, and alternating with the South Campus. So in the Stanford UCSF merger, I was being recruited by now the chancellor, who forced me in the lab for a year at the North Campus, and the president of the South Campus. And the concept was to establish a program in regenerative medicine. We just had embryonic stem cells literally in 1998, and that was the vision. So I was incredibly excited. I didn't know anything about Stanford, but of course I was very grateful to UCSF. Long, complicated recruitment, 2 places, they get divorced. I now am assigned the South Campus because of the Children's Hospital. So we could have been colleagues. You're probably ducking that bullet, and that's fine. But so that was my other disclosure. UCSF has always been a part of it. So we now have probably a dozen MSTP students, and they each have decided, like, bring in their old organ. So inflammatory bowel disease, or after a heart attack, or after a stroke. Those are all scars. Pulmonary fibrosis, et cetera. So now we work on each of these model systems. And I'm kind of leery to say this, but I think I'm getting closer towards a unifying hypothesis for organ fibrosis. There's a cellular culprit, an activated fibroblast, a phenotype that gets activated in response to injury in all those different organs. And we've identified that. So now the question, and we have identified it in chronic injury of the skin, like radiation or bleomycin, pulmonary fibrosis, cardiac fibrosis, tendons now, bowel, et cetera. So I think we're getting closer to having a therapeutic that could target the problems of capsular contracture, adhesions, et cetera, because I think orthopedic surgeons are burdened with fibrosis like we are in plastic surgery. This is an important slide because this is all unpublished work now, either coming out or not, on all those models. So foreign body response, right, which is endemic in millions of implants. We have a paper coming out in Nature Biomedical Engineering identifying SPP1 as a target for both, and this is a breast capsule model, but you could do anything. Adhesions, we have a paper coming out in Science Translational Medicine identifying a target, because at the end of an operation, you could wash out the joint, you could wash out whatever. We wash out the abdomen, and that prevents adhesions in both mice and pigs. Crohn's disease, which has creeping fat and intestinal fibrosis, is an activated fibroblast marker, and a YAP inhibitor will block that, et cetera, et cetera. So pulmonary fibrosis is interesting. A paper that's gone back into Nature a couple months ago that says we can identify a fibroblast subtype that we can deliver intratracheally in a mouse model and prevent or rescue that. So there's lots of help coming. This is a diabetes trial that ended last week. I don't yet know the data, to say that a tension offloading dressing will minimize site complications. If you have a pump or multiple daily injections, you end up ultimately with scarring and lipohypertrophy in those areas and real estate exhaustion. So believe it or not, local site care in diabetes is a major problem. So I'll just go through some of these today. So we're going to start with skin. So this is kind of the big picture. You have a fibroblast that gets mechanically activated. You all know this, either by motion or wound healing. I'm going to try to give you 4 levels of evidence. One is a shrinking dressing. It goes on large, you put like a Band-Aid. You pull the backing off, and it has a shape memory, so it immediately becomes smaller. So you borrow from Peter to offload Paul after surgery. That's treated about 300,000 patients with a couple randomized controlled trials. So that's at the level of the skin. And then we are now going to go inside. So that at the level of skin, you can tension offload and wear something post-operatively that significantly reduces your scarring. Now it's a 14-year journey to get that into the market, and now has treated patients. But inside the fibroblasts are the channels that I'm going to go after, and we've published extensively on this and have a lot more coming. So what I'm going to talk about first is focal adhesion kinase. I just mentioned this because with Jeff Gertner's group, we've published over the last 15 years in multiple models that you can interrupt focal adhesion kinase, which is an integrin cluster on the cell membrane, and significantly reduce scarring in a burn model, incisional model, or even burn skin graft. So that's the second level of evidence, these 2 things. And now I'm going to go through what most people don't realize is I think this is the largest vertical in the US health system that's never had a small molecule in it. So just take a minute and comprehend how big the market of scarring could be just from a surgical standpoint. So you're talking about 80 million operations and lacerations a year in the US, unless they're in utero or inside the mouth, they're going to heal largely with a scar. It's a big burden. People always ask me, are scars important? I said, only if you have one, and only if you have one on a child's face, for example. So I think we have to do a better job of bringing things to the market. I'll just let you take this slide in, which is also always surprising, not to surgeons, but for all scientists. So look at the amount of drugs that have been developed, and look at the small molecules to prevent fibrosis and scarring after surgery. Never. So I hope we're changing that. We're having a pre-IND meeting. I hope in the next 3 to 6 months in the project that we work on in a collaboration with Jeff and people at the NIH. So I'm not going to talk about C-June, which is something that you can overexpress to get a thick scar in a mouse. Humans have two problems with healing: overhealing and underhealing. We're the only animal species on Earth that has a hypertrophic scar or keloid, and we have underhealing problems. So if you try to develop that model, you have to do something. And here's an example of how we were able to do that. I love models that are experiments of nature. You may not know the MRL mice, which serendipitously regenerate the hole punch that you use to mark your transgenic animal, but they heal with a scar in the back. So now you have scar-free healing and scar-positive healing, same mice. And Heather Talbot was able to use a differential allele-specific sequence in genetics to identify the traits mom or dad. And it turns out we were able to do that and then get the back to heal with less scarring. In general, as Jeff mentioned, I'm talking about fibroblast heterogeneity. There are lots of different types of them. And I think we were one of the labs that opened this field up. So this is where we're going to go. So the story here begins 9 years ago when we published a paper that said on the back of a mouse, you have two types of fibroblasts, engrailed negative and engrailed positive. And in response to injury, engrailed positive fibroblasts are the skull culprit in a chronic wound like radiation therapy or desmoplasia around a melanoma, or in response to wound healing. So now we had identified an intrinsic scar culprit in the back of mice. Then we followed that up 6 years later with Shamik Mascharek, who's now a derm resident here at UCSF in the academic track, where I think it's an internship plus 2 years instead of 3, and then 3 years of postdoc. And Heather, who's now a postdoc in the lab, said, do you think mechanical forces activate engrailed negative to be engrailed positive? So it turns out they do. And if you prevent that with a drug that's on the market for a different indication, that you can get true regeneration. And this was painful to do. We had to show that the extracellular matrix is normal, just like unwounded. Scar, for all that heaping collagen, is only about 80% as strong as normal skin. And then you have to have return of secondary elements like hair follicles and glands, because scars are bare. So we had to develop a way we could do that. But we also followed that up with something: how do you form hair in a scar? And it turns out it's TRPS1, which is involved in hypertrichosis, where you have hair all over your body in humans. So this was a nice follow-up to the mechanism of how you get hair. Okay, so now we're talking about a one-time injection of a drug that's on the market. And this would be something you'd be injecting as you close. So we make an excisional wound on a mouse. This is the drug. It's called Visudyne. It's verteporfin, which is yes, associated protein, the final transcription factor when you have physical forces like tensile strain on a fibroblast. This is the final transcription factor that binds to DNA and activates the program. So this better to be lucky than good. And better not to have frontal release as an adult, by the way. But so we have this drug. It's on the market since 2000, and it's used for macular degeneration. And you like things that give you an advantage. So this is injected IV, and then is activated in the light through the light source, a laser through the pupil on the back of the retina for macular degeneration. It has nothing to do with what we're talking about, but it's great that it's approved and treats tens of thousands, hundreds of thousands of patients for IV use. Okay, so I just show you this just to orient everyone. So we put this ring on the back of a mouse because they have a panniculus carnosus, that muscle layer. So if I don't put this on, within a day, this wound will contract. That's not how your patients heal. right? We reepithelialize overgranulation tissue for secondary intention wound healing and contraction. So now we can get 2 weeks of healing, human kinetics, not human scaling, just gives us a human-like kinetics. Okay, so if you inject verteporfin in 4 or 5 areas here and leave this to close secondarily, and you come back a month later, this is the Nair effect where we have to replace the ring every week. This is shocking. You would never see hair in a scar like this at a week. So it wasn't a very subtle readout that we were onto something here. But I can tell you, we've cured a lot of cancer in mice, right? We've cured a lot of joint problems in mice. We've prevented adhesions in mice. But this is the valley of death for me, which is off by a whisker, so to speak. It's not how other people view it. It's going from mouse to man. Most things, 9,999 don't work. So what we're trying to do is, remember the 2 problems this species have, too much or too little. These are 100 million years old, don't have either of them, 100,000 years old. And we have selected an adaptive trait of scarring to survive and procreate. So 100,000 years ago, or the time we became bipedal, if you healed slowly, you got infected, you were debilitated, you were eaten. So the scar is a spot weld that allows you to survive and procreate, and a very recent adaptive trait. So we have decided going to this is too big, too risky, as it would be for obviously any pharma company that has never had it. So this species right here, pig, is the most human-like skin. And believe it or not, there's a red Duroc pig from Missouri that has a little bit of a thick scar, a little bit of hypertrophic, not like our patients do. So the question is, if we wanted to bring that observation of true scar-free healing into human, you need to diversify some of that risk. And so the pig was the next step in this process, and that's what we've been working on for the past 3 years with the support of that Sea Doctor program. So these are large defects. I hope you can appreciate 5x2 hexagonal shapes. So when we close it, it has a uniform strain across it. These are closed in 2 layers, and we're going to inject verteporfin before we close, and that's it, the one-time injection. Okay. And you asked the question, how much would we use? Okay, so if you just scale this up, this is way bigger than that mouse wound. And so we scaled it up, and we predicted this dose right here as our optimal dose based on scaling it up. And it turns out this is at 8 weeks. We have it out 16 weeks, but I'd love it if my patients had that result after 8 weeks out. And you can do visual analog scale, and a surgeon or a layperson could say, oh yes, better, higher score, less scarring, but it's really variable. So that was the first thing, is I thought we were making progress. And then you have to do a sanity check. If you're inhibiting yes-associated protein with verteporfin, you should see less of it here than here with PBS. And I didn't tell you, CD26 marks 95% of the inguinal positive fibroblasts. So we should hit less with verteporfin and less with verteporfin, and we do. That should translate, in theory, to better and better visual analog scores. You can see the blue higher is better here. But again, that's highly subjective. If I ask Dr. Lotz on 1 to 10, Dr. Mann on 1 to 10, everyone has a different opinion of what a scar looks like. So in addition, remember I said you have to have return of secondary elements. Pigs are a little different than our patients, and it's a 1-year hair cycle, so it's quite a bit longer. And the markers that mark them are a little different, but we saw return of hair follicles at 16 weeks, not quite normal, but certainly a lot more than the vehicle. And this is with a long hair cycle, pretty interesting. And you can show that the markers of these hair follicles, it's hair follicle neogenesis by either hair follicle stem cells or the dermopapilla. So everything was a little different in pig, but we're happy to have that behind us. This I'm going to take a minute to talk about. So this Shamik Mascharek and Jason Guo developed an AI neural network that I keep saying that scar variability is highly subjective. And I think everyone knows that. Everyone has an opinion on the scar. How bad is it? How good is it? Patients always think they have a horrible scar. I see patients on Thursday, and that's my life. I don't know why, but that's what I've evolved to. So, but now we said, okay, if we were going to have something that worked on liver cirrhosis, if you ask a pathologist here and you have world-class pathology on a bat slugwood scale, 0 to 4, what is cirrhosis? They would give you it in 0.5, like 1.5, 2.5. But we have 48 million Americans with fatty liver, and I'm going to talk shortly about how fat becomes fibroblast. So I think it's a tsunami of cirrhosis coming. So if we had a small molecule that could block it, could we specifically and precisely say how different it was? So that was the reason for this, to get away from the visual analog scale. So it turns out that you can measure at this time, it was 26 parameters on each ECM fiber, how long they are, how wide they are, connectivity, anisotropy, all those things could be measured. And now it's up to 294. So we have a very specific, either non-overlapping with what we're not interested in is a MEC data set. And I'll show you that in a second, where you have a scar on one side and regeneration on the other. We'd like to see our wounds over on the regeneration side. So the third piece here is the mechanics, which people in this audience know way better than I do. So you can do a longitudinal assessment of the elastic ratio with a cutometer, and you see that there is very stiff wounds with a vehicle, which is PBS here. And as this starts to come up, so it looks like we're going to talk a lot about remodeling, which is something that people know a lot about. So even in the later phase of wound remodeling, verteporfin, many weeks out, 16 weeks later after the one-time injection, still has benefits. You can look here at the stress strain curve. Here's vehicle, here's normal and verteporfin. Here's normal and verteporfin for ultimate testing strength, and here's normal and verteporfin for Young's modulus. So by the parameters, we had created more normal-like unwounded skin than scar. So for this pig model, it was a big step forward to say we're getting those aspects of regeneration that we identified in mice. Okay, so then we said, okay, in the time we're in now with the genomic screening era, could we do single-cell RNA transcript, and how different would be? So I want to take a minute just to give everyone a bit of a background. So I don't think there's a million ways to form a scar. In fact, if I told you we have paper submitted with 12 million cells for all 36 human tumors and 32 mouse tumors, the fibroblasts that are associated in the desmoplasia around the cancer, there's only 4 major types between mouse and man, whether it's breast or pancreas. So there's not a million types of them. There's no new novel fibroblasts involved in scar or wound healing. It's an activated form of a handful. So keep that in mind, that scar is highly conserved. Secondly, we have a paper that we submitted on 6 different species. Some heal without a scar, like axolotl, or the reindeer antler. Some heal with a scar. Some, like spiny mice, heal with less scarring. So those are also expressed in all 6 of those wounds in response to injury, including human. So it's a conserved target. It's not that difficult in my mind. And I'll just make one other point about desmoplasia. When you remove a tumor, the tumor has the tumor itself, and then has the body's response to it. You could say, oh, it's a good idea if you have desmoplasia around a tumor because it prevents growth. But if you're a CAR T person, it's a bad idea with solid tumors because we can't get access to the tumor. So regardless, so I asked a question, a colleague came to me in a grand rounds and said, what about pancreatic cancer? I said, oh, tell me more. Like I've done Whipples, those patients die, it's a bad problem. They said, well, do you think there are different types of desmoplasia? So maybe it's a fibrosarcoma, maybe it's a Ewing sarcoma, maybe it's something you're operating on. So I asked, okay, so we did 500 specimens ultimately of these large Whipple operations. We didn't know anything. We just looked at the architecture of the desmoplasia. I don't know how they were treated. I just know how long they lived. Okay. So it's a paper that was published earlier this year in a new cell spin-out called Cell Reports Medicine, but it turns out it was almost 2 years difference between architecture that was favorable and unfavorable. It had nothing to do with the cancer. So let's not underestimate the body's response to injury, whether it's a melanoma or a Ewing sarcoma. So the architecture of the fibrosis around a pancreatic tumor is the most important determinant of life or death. And of course, my medicine colleagues and oncologists hate that because they haven't been thinking about that. But my point is, let's look at the cancer and let's look at the body's response to cancer, both. So you don't, I think we're going to talk about wound healing, but this has profound implications for other fibroses, including tumors that you treat in your department. Okay, so our first single cell data set, it took a little while because obviously pigs are different than humans. And we end up with 5 fibroblast populations grossly. I again want to make the point that they're in each of the time periods and each of the either control or treated with verteporfin, but some expand dramatically with verteporfin. So it's an enhancement of an existing fibroblast population, not a brand new fibroblast. So we had thought that type 1, there are 5 types here. Type 1 was really enhanced with verteporfin, and types 2 and 4 were really significantly expanded in the scar with PBS. So then I said, okay, so we'd like to be able to get these cells and isolate them. So now we had to develop cell surface markers to identify those 2 types. Ones that we think are involved in non-scarring type 1, and you can see the markers here. And then some including alpha smooth muscle actin, which is not shown here, which are enhanced, that allows us to look and see where they are in response to PBS, as you see here. So now we had a handle on 2 different types of fibroblasts and how we would look at them. So this was a bit of I have spent a lot of time in the last 10 or 15 years talking about fibroblast heterogeneity. And then Shruti Nayak, who is an immunologist that we wrote that science perspective with, said, that's just a lower motor neuron. That's just a cell making the matrix. It's not operating alone. Why don't you look at the immune system? I said, well, I'm still traumatized by my first immunology lecture in medical school, so I don't really want to do that. She said, okay, well, we'll help you. So I was dragged into the lymphoid and myeloid because she said they have to be being coached, right? This has to have some interaction. So it turns out that she was right, that beginning as early as 2 to 4 weeks, this fibrocyte population is really upregulated with PBS and SCAR. And so what I haven't told you is we see a divergence genomically as early as 2 weeks, and it gets wider and wider and wider. It's persistent out to 16 weeks. So this is a one-time injection with long-time benefits. And it turns out that these fibrocytes are myeloid-derived, and they're, as I said, they're more highly present in the scar. So just not to just go through too much technology, but so you can look at single cell RNA sequencing, and then but that is a grind and find, and you lose all the spatial. And so we wanted to get to look at neighborhoods, et cetera, because there's not a homogeneous fibrosis in lots of clinical settings, like pulmonary fibrosis as an example. So you have fibrotic neighborhoods, and it was important for us to look at who's talking to who. So Codex or PhenoCycler is, we have a 40+ panel of cell surface proteins that we can immunolocalize, and we can see the different types of cells, thinking of immunohistochemistry at a large scale. So it turns out that if we look at 16 weeks, we can say, okay, based on cell surface markers and protein, do those correlate to what I just mentioned in RNA? And it turns out that you can identify a more regenerative fibroblast cluster 1 that maps to a Codex type cluster 4, and similarly 2 and 4, which are scar promoting in our hands, a map to Codex 2. And if that's the case, for example, with Codex type 2 cells that are involved in scarring, you should see those enhanced in sections that are treated with PBS, and they are. So much of this is a sanity check. Similarly, things that are upregulated when you're regenerating a wound map to a higher immunolocalization with verteporfin. So beyond kind of the cell surface markers and who's where, there's things statistically like K nearest neighbor. If I wanted to know how much Dr. Lotz paid for his house or something like that, I would look at other houses in the neighborhood and get a range, and you'd be able to figure that out. But and that's a simplistic surgeon's view of K nearest neighbor. So you can also say in this situation, you kind of want to see who's talking to who based on where they're sitting or who lives around them. So it turns out that using this Codex technology, we could identify these myeloid cells, and they were talking to fibrocytes So you can see that who's talking to who more in vehicle scars was important for fibrosis. And you can see if that's important, that the co-localization of those cells in their neighborhoods is seen more in PBS. So that's kind of a tour de force. There's obviously spatial visium, spatial transcriptomics as well that we've been able to integrate. But it's just showing you that we can now dissect the pig, which is the most human-like skin, get wounds to heal without a scar. And it's reassuring to know that the activated fibroblast subtype is present in that other species. Okay, so that's great. We're going to try to diversify the risk of going to this species. So now went back to the Harrison days here at UCSF, and we looked at human foreskin xenografts. Not an ideal model. There's no hair. Collagen super tightly compacted. It has hairless sebaceous glands, which you've probably forgotten about from embryology, called Fordyce glands. So now we're going to put this on the back of a mouse with a depressed immune system. We're going to wait 2 weeks, then we're going to wound it. Now this is human skin, but in a different mechanical environment. It's in the low tensile strain of a mouse. And so now we're going to see how that model, we've published this before, but I'll simply say that once it takes and the contractions out of the system, then you can make a wound, you can inject vehicle into it and see the scar, or you make a similar wound and you see very little scar with verteporfin. So we now thought, okay, the observation is true. We're decreasing scarring with verteporfin in a human skin graft model on the back of a mouse, and this heals with human cells. We can easily tell the difference genomically. It's interesting that we saw an upregulation of IL-33, which was one of those 4 markers I showed you several slides ago that are present in wounds that heal without a scar. Okay, so single cell analysis of the human skin. Just look at the pie charts here. So this is 6 different types of fibroblasts, 5 different types of fibroblasts. These are pretty similar, but they're pretty similar because of the purple here, for example, type 2. This one expands, type 4 in brown, in PBS-treated scars. So we do anchor label transfer to see how similar the observations are from one species to another, in that scar culprit, or the regeneration culprit, maps to 2, which of course was more expressed in verteporfin, and then 4 maps to 4, which is more expressed in vehicle control. So it's just a sanity check that what we're seeing is pretty consistent throughout the different species. This is an observation where, out of Sruthi Naik's work, where IL-33, which was highly expressed in wounds that don't heal, we asked the question, okay, so vehicle, and 14 days later, see that scar, verteporfin, very little scar. But if you take vehicle and IL-33, it's redundant. You still see the scar. But if I told you that type 1 fibroblasts under mechanical forces can give rise to type 2 and 4, and you'd be able to wonder, well, what will be the way of preventing type 1 fibroblasts from becoming type 2? You have wound healing that's crippled. So it's redundant because of the dynamics that are set early on with different fibroblast subsets, IL-33. So I think, where are we with that project, and why did I lead with that? Well, because of the support from the grant that Jeff was talking about. So we have some advantages here. It's approved for IV use. It's been off patent. It's 26 years ago. It's called a 505(b)(2) pathway, which means we're repurposing a drug that's already on the market. And that has some advantages in terms of if you can cite the IND package of how it was got on the market 24 years ago. We filed for IP for anti-scarring, and I'm married to a dermatologist. That's another disclosure if that's relevant. And hair growth is an important market as well. So growing hair in a wound is brutally difficult, but it does raise the specter that we could do something like that if people wanted to treat alopecia. We had an Interact meeting with a consultant, Kim Martin, who was funded by the C-Doctor Consortium. And that was interesting. That's even before the pre-IND meeting. And they agreed with lots of things we are doing, which is interesting. It doesn't mean much. So now we're putting together a pre-IND package for some time in the next few months. But it turns out Allergan, which makes Visudyne, did not want to work with us on this. I don't know why. I think it's a little irrational because the scarring market is a lot bigger than the macular degeneration market. I'll say I probably get 100 emails a week from surgeons and dermatologists around the world who are buying Visudyne and injecting it in their patients after scar revision. So I can't control that. That's not what I want. That's not what anyone wants, but there's a lot of excitement about it. So we're putting a pre-IND meeting together. We're going to use the same active product ingredient that we have with Visudyne, but we're going to modify it slightly such that we don't change it significantly, but it gives us potentially a composition of matter patent versus what we have now, which is a method of use. So I think if it's an investigator-initiated trial, me being the PI at Stanford, and we're doing 15 patients of not infants, these would be teenagers or adults, we're not clear on what that is, for cleft lip scar revision. So you excise the scar, you inject verteporfin, and you close it, same surgeon, and this is part of their care. Children with clefts have many operations throughout their life as a result of fibrosis, speech, swallowing, bone growth, etc. So that's the indication. It's not the largest indication, but as a craniofacial surgeon, it's one that's near and dear to my heart. So if all goes well, I'd like to have a first in human coming. It's, as Jeff said, it's been a long time since October 1987, but I believe we've diversified enough risk that we're moving forward. What I didn't tell you is we did non-wounds with derm tox based on other projects that were funded for this. So we've done a lot of things that they would ask for. And so we're hoping the GLP studies are just 1 or 2 pigs, because what I didn't emphasize is these pigs have 10 wounds each. So this is probably 200 times the dose that they would have on a human, and it's 1/150th of the dose that you get IV, and it's gone in a day. So lots of things in our favor, but still with the FDA, you never know. Okay, so the next thing is the relationship of sub-Q fat to scarring. And you probably know this, but scars are widest down at the bottom. It's a triangle. What the patient is annoyed by or you're annoyed by is the tip of the iceberg, so to speak. So is there a relationship between this? And always go back to the observations, right? These are the hands of someone with scleroderma. After radiation therapy, the sub-Q fat is melted away. So there's not a lot of fat seen in skin lesions that have fibrosis. So an inverse relationship. I didn't tell you that when we inject verteporfin into the pig scars, we see accumulation of fat versus in the scar. So we believe there's a dynamism between sub-Q fat and scarring, and now we're asking a question. So Michelle Griffin is a postdoc here, Michelle's an interesting person. She's the third person I've had with conviction such that she did her MD, PhD in London, full training in plastic surgery in London, but there's no concept of a 50-50, 60-40, 70-30. Because of the NHS system, there's just lists all day. There's not the academic surgical opportunity there. So Michelle came over and did a 4-year postdoc with me, and now is in her 2nd year of retraining for 7 years in plastic surgery. This is the 3rd person I've had do it. 1 had orthopedic surgery training already and 2 plastic surgery. So that's pretty strong conviction. And Jen is an MD, PhD student. So they asked this question, right? Do fibroblasts transition, adipocytes transition to fibroblasts and contribute to scarring? So I think it's always important to acknowledge you didn't make this up, right? There are other people who have thought of the role of adipocytes in wound healing. Max Plikas's group, long time ago, Valerie Horsey's group. So full disclosure, we're asking specifically in scarring, not in general in response to injury. So 2 simple questions here. Do they transition to fibroblasts in response to wound healing? And if we prevented that, what would be the consequences for scar prevention? So if you take red adipocytes, just keep it simple, you inject them in the back of a mouse in an unwounded area, and you come back and wound that area, you will see lots of red cells. And those red cells have lost fibroblast markers and they've lost adipocyte markers. We're putting adipocytes in and gained fibroblast markers. So that's interesting, but reviewers will very kindly, not kindly, point out that you could have a single red fibroblast in there disproportionately contribute. So we had to then say, okay, what about the transgenic model here? So now we're going to have green fibroblasts when we make this, and it's not going to be cells that are injected. And I'll simply say you see lots of green cells 14 days when the wound heals. they lose their adipocyte markers, they gain fibroblast markers. These are lipofibroblasts for those interested in the types of them, and they co-localize with fibrotic signals. So if you do single cell sequencing, this is a little bit more complicated because it's a rainbow mouse, but I'll simply say that we're looking for things that are not green, and this pie chart here jumps out at you as having not much green. It's this type 3 of these 5 fibroblasts. And it turns out that those clusters, that cluster 3 doesn't make FAK, doesn't make a lot of YAP, doesn't make a lot of piezo. So I'm speaking at an institution where piezo won the Nobel Prize for pressure and pain sensation on the tongue. So that's a pressure sensitive calcium ion channel. And it turns out that cluster 3 lacked those things. So you can begin to say, okay, an adipocyte can become a fibroblast initially mechanically naive, and this is other things I'm not telling you, that mechanical forces are sufficient in and of themselves in a dish or on the animal to activate an adipocyte becoming a fibroblast. Also, piezo 1 and 2 are much more highly expressed in adipocytes, so this is not like the fibroblast model. So now the question is, can you take that intermediate stage and can you inhibit that with piezo, something not like YAP or FAK? It's much more highly expressed in adipocytes. So this is a different target now. And it turns out we'll go back to that same animal, the same model where we see a scar at the end of the excisional wounds. But now we're going to do a one-time injection of this one. We've talked about this, we've talked about this, now we're here. So let's see what that gives us. So it turns out that if you inject piezo 1 or piezo 2 inhibitors versus a PBS control, underside of the skin, we see accumulation of fat, we see the return of hair follicles and fat, and we see more normal-like appearance. This is that data set I was describing with the algorithm. So here's what a scar looks like, and here's what normal skin looks like, and the piezo 1 and piezo 2 are completely a MEC data set where they're completely overlapping normal. But you can have off-target effects of a small molecule inhibitor. You don't know where it's going, who's it really working on. So if you knock out piezo 1 and piezo 2, you have a much stronger data set. And it turns out you see accumulation of sub-Q fat and hair follicles, and piezo 1 is the best compared to the bare area you see with control. So this again, with the algorithm looking at 294 features, we see it totally different than scar and completely overlapping with normal skin. If you look at that single cell analysis where I've talked about several times, this is 6 different fibroblasts. Again, only a handful, not a million. And you look at all these conditions at the end. So then you can do some sorting and say, okay, that type 3 mechanically naive cell, is that also present when we do a knockout or piezo 1? And it turns out it is, and it's expanding. So the mechanically naive cell type of fibroblast expands when you block piezo mechanosensing in fibroblast adipocytes. Okay, so we're able to prevent scarring now, but this is really the holy grail. I don't know how many people in here deal with scar revisions. It's the bane of my life. It'll be the bane of my life tomorrow morning with patients wanting a scar revision. The problem is the scalpel is not the answer. The biology always trumps it. And now they paid me cash money, and a year later, they're unhappy. I do not do scar revisions because I can't change the biology. I don't know what people in the audience think, but that's just how I've evolved over the last 30 years. So could we, however, rescue an existing scar? This would really be scar wars. And now for the trainees in the audience, I'm sorry if you've read those wound healing chapters. I'm guilty for writing them. And this is what I wrote, right? Inflammation, proliferation, remodeling. No one knows what this is, right? Just something. This is not true, because now we have the ability to look at wounds and transcriptionally. In a paper we published, Deshka is a surgical oncology fellow at Memorial coming back, and Mike Janicek and his instructor, where we looked at integrating genomics with spatial and proteomics with spatial. And it turns out that here's what I've written in chapters, right? And now if you're marking keratinocytes, we have this pretty accurate, right? They're migrating over and then they migrate over. The thought is reepithelialization calms down the dermis. I've written it many times. Remember, surgeons are often wrong, but never in doubt. So I always thought I was correct until I started to see this, right? So activated fibroblasts after reepithelialization are quite activated, and inflammation is quite active. It's not as simple as that. I didn't have it right. So now you begin to think, okay, so now there's a much longer window of inflammation and remodeling. But those patients in your office or my office who are not happy with their scar, guess what I tell them? You're going to heal on the inside for the next 2 or 3 years. Let's wait and see. I'll see you every year. Just getting them out of my office, frankly. And the patients are obsessed with putting creams and lotion. So $1.9 billion of stuff our patients put on in the first year after their operation with no level of evidence. So that's how much people are wanting to participate in scarring. So this then said, well, if this is long time and it's really you're healing on the inside, can we inhibit that cycle? So same two people who are much more talented than I am said, okay, we're going to make a wound on the mouse. We're going to let it heal for a month. So now we're going to come back and there'll be hair, no hair, and a bare area. Now we're going to inject into that 1-month-old scar, we're going to inject a piezo-1 inhibitor, and what's going to happen, okay? So you don't really have to say anything with a result like this. This is a scar. It's a scar 30 days later. This is a scar. Whoops, what's all this hair doing here? And you can see the dramatic difference here, right? So you are remodeling an existing scar in 1 month in this animal system. I said, okay, kind of how low can you go? How long can you go? So now we said, okay, if we wait 2.5 months, or if we wait 4 months, now 4 months in a mouse is probably like 25 years in lifespan. So now we're going to have very established scars. And the readout here is so simple, it's just hair, right? There's no hair in a scar. So here's what we see at 105 days, 30 days after this. Here's what we see at 150 days after a 4-month-old scar. And I put the ends here because in a Gordon conference recently, people thought this was too good to be true. So now I'm going to show everything in a paper that's going in. So you can see where there's more or less hair. There's always hair in there, and that's our quick readout of a scar. So on this part, I think fibroblasts can be derived from adipocytes. It happens in response to mechanical sensing at the base of a wound. And if you block that, you can both prevent and rescue. And that's shown as a cartoon here. So I hope I've convinced you, or at least you might start to believe, that there are 4 levels of evidence that all support that inhibiting mechanotransduction, whether it's from motion, muscle, or it's part of wound contraction. If you inhibit that, you can significantly prevent scar formation. So, and the reason I'm excited, these are all different pathways. Any one of them could be inhibited, but the biology supports all of them. Just want to thank the funding sources. And again, I'm thrilled to be back at UCSF, and thank you for the opportunity to present. Thank you.
All right. Thank you, Dr. Longacre. That was fantastic and really incredible work, and so interesting to see the translation into have some hands up, and we'll start passing around the microphone.
Thanks, Mike. That was awesome, as always. I'm wondering if you could now reflect back on that initial observation with Mike Harrison about the fetal lack of scarring and maybe where you are now. What do you think is the protective mechanism in embryos or in fetal environment that prevents scarring?
Great question, Rich, and nice to see you. Thanks for coming. So in what we were talking about a lot today. So when I was forced in that lab, initially, probably the first half to 2/3 of long gestation models, lamb, human, etc., you have the skin is not a barrier. So it's like a gelatinous layer with periderm, like the villi and microvilli of your gut. You secrete things in amniotic fluid, you absorb things through amniotic fluid. In fact, most of amniotic fluid is made by the lung as time goes on. So you urinate and swallow. I know that's not how you visualized your first 3 trimesters, but that's what was happening. At some point, though, the skin becomes a barrier. And when that happens, we're tight skinned. So that if I operate on a 97-year-old person, like my mother, I would never do that, by the way, but she skin really hangs and has the elastic snap is gone out of it, solar elastosis. So if you live to be 95, the good news is you're going to heal with 1/20th the amount of scarring you did as a teenager. So tight-skinned animals, which happens when skin becomes a barrier, is in the last trimester. And I believe that's it. That sets mechanics. If you operate on a 12-year-old girl's shoulder, the gapes open, you know that's going to be a wide, thick scar. And that's because we're tight-skinned animals. So that's my simple explanation. We did hundreds of experiments to get adult skin in the fetal environment. It does not revert back to its phenotype. It heals with a scar. You can take the tail and pick it out of the intrauterine environment. It heals without a scar even there. So I think it's simple mechanics when you become a barrier. If you make an incision a bowl of Jello, it doesn't gape open, right? But if you make an incision a bowl of Jello under strain, it does gape open, and that's the dynamics with a tight-skinned animal.
Hi, I'm fascinated by your findings with the rescue of the scar, and because I don't often see people talking about changing that matrix once it's formed.
Because it's not thought to be possible.
So, well, my question was, how general do you think that is beyond skin? You were talking about the fibers around pancreatic cancer earlier.
So as I said, I probably get 100 emails a week by people doing scar revision, but they're doing it. This paper, that information hasn't been published yet. Those two papers have gone back in. But to inject the scar, and if we could significantly improve it, I think you'd have patients lined up from here to Chicago if we could do that. I don't know if that's possible yet. These are loose-skinned animals. But the concept of a scar revision, which I don't do, put EMLA cream on, cut the scar out, inject verteporfin, and close, that I would do that all day long if it worked. So the answer is, I don't know, but I'm going to bet on it that it worked. What I didn't tell you is one of the two randomized controlled trials in the tension offloading dressing were 10 scar revisions. So the N of 10 tells you that. So they were done by other surgeons, excise the scar, close it, same technique, half get Steri-strips, half get that dressing. It was only 10 patients required to see significant improvement. So do I believe that if you inhibit mechanotransduction and fibroblasts after scar revision, we could, for the first time, inhibit it, you get an improvement? I do. I haven't done it though.
Hi, Dr. Longacre, back here. I spend a lot of time thinking about fat in non-healing wounds like osteoarthritis. So I'm really interested in the idea of adipocytes in healing wounds. And I'm interested in two components based on your group's beautiful work on identifying the skeletal stem cell. Are you looking at a stem cell population or how that niche might change in response to verteporfin? And also, what do you think the dependency of age might be in the success in its role in wound healing?
So thank you for your question. As I said, half my life is thinking about osteoarthritis. So we published a paper about a year ago in Nature that said with aging, there's an inflammatory niche that occurs that significantly modifies how skeletal stem cells respond to an injury or an injury model. And that can be reversed with different targets. So it's true, even in the skeletal stem cell population, that niche is impacted by aging, as in everything. And it's an inflammaging, it's an inflammatory process. So that would be the short answer there. That model system is now in mini pigs. And I've seen the first data, knock wood. Again, it's a little painful because of Chuck's passing, but I think we're highly encouraged by it. So I think we're going to order some more mini pigs. This is for you, those of you who don't know, we published a paper several years ago in Nature Medicine that if you do a DMM, I think you would call it, where you take an ACL, take the cartilage out in a mouse, they get arthritis, and then we do microfracture surgery as a way to activate the stem cells. And then we coach them not to go to bone by inhibiting vascular supply and providing BMP. So that will give you cartilage regeneration. Whether that works in a larger animal is exactly the risk we're addressing now. So does it change? So it turns out it's still the same, but the expansion of the mechanically naive one, I went through that pretty quickly on when we do our anchor label transfer in different models. But yes, it does enhance a pro-regenerative fibroblast subtype.
Just a quick question. Quarter century ago, I think your name was probably on the paper. So Mike Harrison and Bob Namby here did N of 2 fetal cartilage injury with scarless healing. To my knowledge, that's still the only example of that. and it doesn't fit the skin barrier model. So what do you think was happening in the fetal cartilage wound healing environment that allowed for scarless healing of the articular cartilage?
So I'm not on that paper, but I do, and I didn't review the paper. So I have no knowledge of what's going on in that dynamic, other than if it's anything like we're seeing in skin, that those populations, as they mature, acquire the trait to be able to scar, to survive and procreate. That's my simple answer. I was not involved in that study, so I can't comment beyond that.
Mike, great job. Thank you. This is very impressive. You know, got us really thinking. I want to kind of bring this to orthopedics a bit because I think skin heals very fast, right? You know, epithelial in a couple of days, you take the stitches out like a week later. We do a lot of soft tissue surgery, orthopedics, ACL you mentioned, rotator cuff. They take months to heal. They a lot of work on speeding up healing, and also can we heal better? Because right now we heal by scar tissue, granulation tissue doesn't reproduce the same kind of insertion, you know, kind of characteristics. They work on that area because that will be again a lot of huge, you know, improvement in our field and to help a lot of people.
Perfect. We're in violent agreement. That's a whole other area in the lower right area of tendons, ligaments, and soft tissue that we're working on. And the advantage of that is the longer time period for healing. So I refuse to accept that a scar is what a healed tendon repair looks like. I don't believe that. It's not as strong as normal. So Joe Wu Tsai, I don't know if they have a Wu Tsai component here, co-founded Alibaba with Jack Ma, and Joe and his wife is a Stanford grad. So they gave $200 million to regenerative rehabilitation. So I'm working with tendon, ligament, and muscle with investigators at University of Oregon for this question. I don't have the data yet, but it's really exciting because I realize, you know, can we regenerate that and have as strong a tissue as we had? Because we're interfacing with bone, we're interfacing with other ligaments, we're interfacing. Now I'm told that you don't always repair an Achilles tendon. Is that true? That's what someone told me. So I'm a dinosaur. So I need to pay attention to orthopedic colleagues, but I think orthopedic surgeons absolutely struggle with fibrosis. There's an example. They may not think of it. Yes, if you're doing a Ewing sarcoma and you have radiation, you have a lot of fibrosis or joint contractures, but you're not spared from it. Its skin and its contents are fibrosis. So yes, it's a huge area, huge and growing in an aging population.
I think we have more questions both in person and on Zoom, but I think we'll have to wrap up there. But Dr. Longinger, thank you so much. We have a plaque to commemorate your visit, and then we will have a journal club to follow. If anyone interested is welcome to stay.
Thank you so much. Happy holidays to everyone.